Thank you to Professor Usman and the team at the Asian Stroke Conference for the great opportunity to speak and discuss with you about navigating thrombectomy in large core infarcts. My name is Tan Nguyen, and it's a great pleasure and privilege to be amongst you today. Large ischemic core comprises approximately 1 in 5 patients with a large vessel occlusion. This is a nice study by our colleagues in Buffalo who found that as time goes by with late windows, you can see a higher proportion of patients who present with large ischemic core compared to the early window. The Hermes meta-analysis looked at patients who had large ischemic core defined as aspect 0 to 4, and in the small subgroup analysis, they found that there was a signal of better outcomes with thrombectomy in patients who had this large ischemic core compared to medical management. And this spawned the birth of several randomized trials looking at patients with large ischemic core to see whether it confers benefit in patients who have this condition. And so patients were enrolled with large ischemic core across multiple countries, including Asia, Europe, and North America. And this is a summary table showing the 6 randomized clinical trials and the selection criteria that patients were eligible for. Patients could be enrolled either by aspects categorization, so aspects being a semi-quantitative categorical score. With if you do an MRI, you'll see lower scores than on CT scan. And the other method of enrolling patients was by looking at ischemic core volumes. So this was defined by an ischemic core volume of 50 cc's or greater in the SELECT-2 trial, or 70 cc's or greater in several other randomized trials. We did a meta-analysis combining these 6 trials together. This is study level, and found that overall the signal is in favor of thrombectomy to improve outcomes in patients with large ischemic core with a 1.6 odds of improvements in the 90-day modified Rankin scale. And if we break this down a little bit further, you can see when you look at dichotomized modified Rankin scale, meaning functional independence, 1 in 5 of your patients will be independent with thrombectomy compared to 1 in 10 with medical management. So you can see that the majority are not independent, but this doesn't change the fact that you can modify this effect with the thrombectomy intervention. And then if you look for the endpoint of independent ambulic as a 90-day endpoint, you can see that 1 in 3 patients will be independent with walking as compared to 1 in 5 patients with medical management. So these are all endpoints and metrics that we would strive for when we propose thrombectomy to a patient with large ischemic core. Of course, the concern of symptomatic intracranial hemorrhage arises in these patients because when you reperfuse a large ischemic core, the concern is that you're going to have reperfusion injury and hemorrhage. And so across the meta-analysis of these trials, the randomized trials, the symptomatic intracranial hemorrhage risk was extremely low, about 5.5% in the EBT arm compared to 3%. And the question is, why is that? Why is it that patients have such a low risk of symptomatic hemorrhage compared to medical management in these randomized trials? And the answer can lie in the fact that in these patients who present with a large ischemic core, for the most part, they already come in with a high NI-stroke scale. So to see deterioration of 4 NI-stroke scale points, which is the definition of symptomatic hemorrhage, may be harder to detect or may be harder to adjudicate compared to patients who have small ischemic core who may not have as great NI-stroke scale on presentation. However, in real life, observational meta-analyses of patients who do present with large ischemic core, we found a higher risk of symptomatic hemorrhage, which we quote as 10%. That's what I would quote in real life because it may not be as easy to emulate what is done in optimized settings of a randomized clinical trial. A question that arises is whether the size of the infarct matters. And so this was evaluated in our meta-analysis. And so we looked at size of infarct at baseline being 70 cc's or greater, 100 cc's or greater, and then 150 cc's or greater. And there didn't seem to be any difference in this baseline ischemic core volume. Patients benefited all the same with thrombectomy, although the sample size numbers in each subgroup, especially as you get to larger ischemic core volumes, is smaller. We then looked at very large size infarct core as defined by aspect 0 to 2, and in the subgroup of imaging core lab adjudicated aspect 0 to 2, across 6 trials, you can see that in overall there is a benefit for aspect 0 to 2, but the caveat is that most of this benefit really came from the last trial. So the last trial was the trial conducted in France, and the imaging modality used in more than 85% of their patients was MRI. So your ability to pick up large ischemic core is much better on MRI compared to CT. So if you remove last from this analysis of aspect 0 to 2, you can see that we don't have significance in terms of showing the benefit of thrombectomy compared to medical management. Therefore, this aspect 0 to 2 subgroup using conventional imaging remains a big question mark. The other question is, does it matter in showing whether or not thrombectomy benefits patients with large ischemic core? And so in SELECT 2, they looked at this across subgroups, 12 hours or greater, or 6 hours or greater, and there was still benefit with thrombectomy compared to medical management. And then Angel Aspect, which is this trial conducted in China, also looked at this and found that at 13 hours and 22 minutes, this was an inflection point after which we did not see significance of benefit with thrombectomy, although the point estimates were still in favor. And TESLA, the randomized trial that used mainly or only non-contrast CT for selection of patients, what you can glean is that in the 0 to 6 hour window, you can see wide absolute differences in treatment benefit with thrombectomy compared to medical care. And this gap narrows as you go into the 6 to 24 hour window in terms of showing any improvement with thrombectomy compared to medical management. Another question that is really intriguing in patients with large ischemic core is whether the idea of having a penumbra core mismatch matters when you select these patients. And so classically, when we go after any clot or any ischemic stroke, the goal is to salvage the penumbra, which you see here in green, and then you expect that the core, which is in red, is the part that would continue to evolve into an infarction. And so several definitions of this penumbra to core mismatch, penumbra being the green part and the core being the red part, have been proposed over the years. In diffuse 3, they used the mismatch ratio of 1.8 and then a volume difference between penumbra and core as 15 cc's. And then another definition that has arisen is from the EXTEND trial, where the ratio was proposed as 1.2 between the volume of penumbra to core, and then the difference in volume being 10 cc's. So these mismatch definitions were further evaluated in the 2 trials that had perfusion imaging routinely done to select patients. And what they found was that when they combined these 2 patients together, meaning those who had no mismatch based on those definitions, so you're getting thrombectomy or medical care based on no mismatch, they still found a benefit of thrombectomy even if you had no mismatch criteria. Albeit the number of patients is not very high, we're in the 160 number range, but still it raises an intriguing idea is that what we thought is the core or what we thought is the penumbra may not matter so much in patients with large ischemic core when we think about reperfusion in a timely manner. So the aspects has many nuances that should be discussed when we think about how do we treat patients based on potentially non-contrast CT. Do you look at the cortex or the subcortex? Do you look at the gray-white differentiation when you look at early ischemic changes? I do. What window level settings are you using? What is the role of edema when you're selecting these patients? And there are many shades of gray when we look at patients with a large infarct. So on the left-hand side, you can see a very obviously dark hypodensity, whereas if you progress across the right, you can see the hypodensity is not as apparent. And so the SELECT 2 group looked at the severity of hypodensity using manual delineation on a non-contrast CT. So what they did was they looked at the Hounsfield units of the side that was ischemic and compared it to the contralateral thalamus, and they found that the median density of the thalamus was 38. And then if you wanted to be at the 5th percentile in the confidence interval, then it was 26 Hounsfield units. They considered that severity of the hyperdensity threshold would be 26 Hounsfield units. And so when they did the whole ischemic core volumes by manual delineation, what they found was that the higher the volume of low Hounsfield units, meaning 26 Hounsfield units or lower, then the less likelihood of your benefit from thrombectomy. And the magic number was also 26 cc's. So if you had more than 26 cc's of less than 26 Hounsfield units, your probability of benefiting from thrombectomy lessened with more hyperdensity. So in summary, no significant benefit of thrombectomy in patients with increasing volume of severe hypodensity on CAT scan, but if you had substantial volumes of severe hypodensity, this was associated with more cerebral edema and higher need for heavy craniectomy after thrombectomy. And so these results are summarized in a paper published in Stroke by Vignan, Yoga, Kumar, and colleagues. And this was also qualified in the Tesla randomized trial where instead of looking at Hounsfield units, they looked at the net water uptake. And what they found was that in these patients who had baseline aspects 2 to 5, presenting within 24 hours from stroke onset, that both the ischemic core volume and the degree of lesion hypoattenuation on admission CAT scan modified the effect of thrombectomy on functional outcomes. Another question that arises is, well, what about patients who you cannot recanalize? What happens to these patients when you have a large ischemic core and you compare them to those who are medically managed? And so we looked at this in the Angel Aspects randomized trial, which is the trial with the most number of patients, and despite having the most, they only had 43 patients who had failed recanalization with thrombectomy. And what we found was for the primary outcome of very poor outcomes, meaning MRS 5 and 6, we didn't see a difference between these patients and those who were medically managed. But we did see in the unsuccessful thrombectomy patients higher rates of ICH, more infarct volume growth, and more rates of craniectomy than in those who were medically managed. So, all to say that the large ischemic core literature has really lowered our threshold to treat patients in a timely manner with a large ischemic core, whether it be aspect 0 to 5 or by volume of core 50 cc's or 70 cc's or greater. And why this matters is because when we think about selecting patients and the imaging modalities we use, you may surmise that several guidelines have issued statements about the use of perfusion in the late window, but because now we are really lowering the threshold to treat these patients, we may not be so accurate in needing to know how much infarct core volume you have at baseline. You can just look at a CAT scan and make a decision right there if you're going to take the patients for thrombectomy or not. And so this is an example of a patient who who came in with a right MCA syndrome with left-sided weakness. And you can see that we scored him in aspects of 5 based on the hypodensities as you see here. And this is the clot in the right carotid terminus, which we removed after 1 or 2 passes and achieved complete reperfusion. And as you can see, there's like a moderate to large infarct on the follow-up MRI. And so I was expecting to see this patient kind of sporadic because he had, moderate to large infarct on arrival and also on the post-procedure MRI. But I was surprised when I rounded on him that he was anti-gravity in his left arm and leg. This is not for social media sharing. And the reason is because when you look back at the MRI, he spared the motor cortex at baseline by the use of probably leptomeningeal collaterals, and that's why he was able to make such a good recovery. So, how do we summarize these findings into guidelines? The Society of Vascular and Interventional Neurology has issued guidelines in patients with large ischemic infarct, such that in patients with ICA or M1 large vessel occlusion in the early window, 0 to 6 hours, who have aspects 0 to 5 on non-contrast CT or MRI, EVT is recommended. And then if they come in later windows, 6 to 24 hours, with ICA or M1 large vessel occlusion, and they have aspects 3 to 5 on non-contrast CT or MRI, EVT again is recommended. However, if they come in the late window and they have aspect 0 to 2 on non-contrast CT or MRI, we do acknowledge that the benefit of thrombectomy is not certain, so we don't know if it can help the patient or not. So that remains a gap in from our literature is what do you do about aspects 0 to 2 with CT selection? What do you do with the degree of hypodensity? How do you apply it in clinical practice? If you don't have the software to automatically calculate it, what is the role of mismatch in the small and large ischemic core stroke, and what is the use of adjunctive therapy in these patients? What adjunctive therapy can we use? So in conclusion, a large ischemic core predicts a lower likelihood of doing well with thrombectomy, but does not modify its treatment effect. Earlier treatment is associated with greater likelihood of benefit than later treatment. Patients who present with aspects 0 to 2 by non-contrast CT, this is still an uncertain area, especially in the late window. And even if you don't see a perfusion mismatch in these patients with large ischemic core, we're still seeing a benefit with thrombectomy. And the greater the volume of severity of hyperdensity on CAT scan, the lower the likelihood that we will see benefit with thrombectomy compared to medical management. All to say that a simplified imaging protocol using plain CT and CTA can be feasible for thrombectomy selection in light of these large core data. And with that, I wanted to send you greetings and hope to see you at the SBIN annual meeting next month in November, and I hope you have a great meeting in Jakarta. Thank you.
Fascinating insight. Thank you, Dr. Tan. And now our final presentation before our discussion will cover revascularization therapies in patients on oral anticoagulant. Our next speaker joins us from the beautiful country of Slovenia. Let's extend warm welcome to Professor Sandra Frohl. Professor Frohl is a neurologist and academic from the University Clinical Center in Ljubljana, bringing years of dedicated clinical and neurological experience to our discussion today. Professor Frohl, we are delighted to have you with us. I hope your journey to Indonesia was comfortable. We look forward to your presentation. Please.
So thank you very much, and thank you the organizer committee for inviting me. So I'm going to talk regarding revascularization treatment in patients on oral anticoagulation. So what are the current advances, and of course what are the future direction? Regarding the oral anticoagulation, we have the warfarin, and then we have the direct oral anticoagulants. So the DOACs or the NOACs, as you can read in the literature. We were using the warfarin in primary and secondary stroke prevention for the decades, but we still need to prescribe warfarin in some cases of the patients with an acute ischemic stroke, with severe renal or hepatic dysfunction, still definitely in patients with mechanical heart valves, patients with antiphospholipid syndrome, and according to the guidelines, we still need to prescribe the warfarin in patients with the cerebral venous thrombosis. But maybe to mention, regarding the patients with the CVT, we are already prescribing the NOACs or the DOACs in this patient subpopulation. So the DOACs, so the direct oral anticoagulants, are definitely the first-line treatment in primary and also in secondary stroke prevention in patients with non-valvular atrial fibrillation. So the DOACs are the thrombin and the factor Xa inhibitors. The thrombin inhibitor is called dabigatran, and the factor Xa inhibitors we have rivaroxaban, apixaban, and edoxaban. And of course, we are prescribing all those for DOACs. According to the better safety and also efficacy, the number of the DOAC treated patients is rising up rapidly. So we are only prescribing the warfarin in selected patients. Maybe just going to the randomized controlled clinical trials, comparing the DOACs versus warfarin. There were several trials for each of the DOAC, and what was important that the incidences of the strokes, so the ischemic strokes and also the hemorrhagic strokes, were lower in patients that were prescribed the DOACs compared to warfarin. So the DOACs are at least effective as warfarin in the prevention of the acute ischemic stroke. But maybe just to mention for the dabigatran in the standard dose of 150 milligram, it was definitely superior over the warfarin in the RELY trial. What is also very important are the incidences of the hemorrhagic stroke, so the intracranial bleedings. All the DOACs are definitely much safer compared to warfarin according to the randomized control trials. Although the DOACs are very effective and also of course very safe, there is still approximately 1 to 2% of patients on the DOACs that still suffer an acute ischemic stroke. According to the warfarin, we have very clear guidelines, the American guidelines, when we can treat the patient with the IVT and endovascular treatment. So in cases of warfarin, it depends on the levels of the INR if the patient then suffers an acute ischemic stroke or hemorrhagic stroke. But from the daily clinical practice, we know that it's always not the exact level that we measure. There are still some patients that have lower levels of the INR and can suffer an acute ischemic stroke. So what do we know regarding the treatment of an ischemic stroke in patients on oral anticoagulation? We always need to have in mind that those patients definitely need successful revascularization treatment, which includes the intravenous thrombolysis, so the IVT, and the mechanical thrombectomy in cases of large vessel occlusion. Regarding the intravenous thrombolysis, so the earlier treatment, the bigger benefit. This is very clear from the clinical trials, from the meta-analysis. So we need to treat the patient as soon as possible. Regarding the warfarin, according to the guidelines, if the levels of INR are below 1.7 or 1.7, we can treat the patient with IVT. In case of large vessel occlusion, we treat the patient with endovascular treatment. What about the patients on DOACs? The EASO guidelines are quite clear. So if we have a patient on dabigatran during the last 48 hours before stroke onset, we shall treat the patient first with the idarucizumab and then proceed with IVT. Regarding the patients who are on factor Xa inhibitors during the last 48 hours before stroke onset, so the use of the specific antidote, which is called andexanet alpha, is suggested against. So why? Because we know that in the ANNEXA-4 trial, about 10% of patients suffered thrombotic events, so we should not treat the patient with andexanet alpha and then proceed with intravenous thrombolysis. What about the ERA practical guidelines? Are quite the same as the EASO guidelines. So for the dabigatran, we shall give the patient first the idarucizumab and then we proceed with the intravenous thrombolysis. For the patients on apixaban, edoxaban, and rivaroxaban, we can treat the patient with IVT if we have all the levels of anti-10A specific for apixaban, rivaroxaban, or edoxaban below the normal levels. So if we do not have those measures, we cannot treat the patient with an IVT according to the guidelines that are, let's say, available right now. While it is very important that the patients who are treated with IVT, they need to be in the stroke unit. I will first start with the patients on dabigatran treatment. So what is idarucizumab? Idarucizumab is a monoclonal antibody which is very specific to dabigatran, and it's a very huge molecule compared to dabigatran. What is very important that the reversal of the anticoagulant effect of dabigatran is achieved within minutes. So it is very specific to dabigatran. It has no procoagulant activity, which I think is a very important fact, and it's very simple to use it as a bolus of 5 gram IV. So we use idarucizumab in cases of ICH and also before intravenous thrombolysis in a dose of 5 gram intravenous. So the administration of idarucizumab before IVT is definitely consistent with the product labels. The first biggest cohort was published by the German neurologist. They included 80 patients. They treated with idarucizumab prior to IVT. What we could see from their group population was that they did not report any bleeding complications, which I think is the most important part. The mortality rate was super low. It was below 4%. And they did not observe any thrombotic events, and the patients had very good functional outcomes with the clinical improvement in almost 80% of patients. I've done a very nice systematic review with some colleagues from Greece. After this publication, it was in 2021, so quite a far ago. We collected all the data of the case report and the case series that were treated first with idarucizumab and then followed by intravenous thrombolysis. So what we found out, that the rate of hemorrhagic transformation was about 8%, but that the symptomatic ICH occurred below in 4% of patients, and the mortality rate was 8.4% of patients, which is again very low. So our findings were consistent with previously published studies in non-anticoagulated patients. After that, we proposed the standard operating procedure, how to treat the patients with an acute and hemorrhagic stroke on dabigatran. This is a very simple algorithm. So if we have a patient who is eligible for IVT on dabigatran, so we shall first give the patient the idarucizumab and then proceed with the intravenous thrombolysis. So the dose is very simple, 5 gram of IV. Maybe just to mention, there are already several case reports of the use of idarucizumab in mobile stroke units. Why this is important, we can also additionally reduce the door-to-needle time to IVT. And for the patient taking the factor Xa inhibitors, once again, the EASD guidelines, they suggest against the use of the specific antidote, so andexanet alpha, prior to IVT, but we are using andexanet alpha in patients with an ICH. We also published an SOP in our leading article in 2023. So a patient on factor Xa inhibitor on the left side, it is clearly not to use the andexanet alpha prior to IVT because of the higher incidence of thrombotic events on those patients. But recently, there was a very important paper published in Stroke. Our center was also collaborating in this study, which was called the Do It Registry Study. It was a retrospective part, but now it is also the prospective part that is running from lots of centers. So we gather all the patients who were treated with intravenous thrombolysis on the DOACs, not just the patients on dabigatran, but also other patients on factor Xa inhibitors. And what was the major take-home message or the conclusion of the retrospective Do It trial? That the IVT in patients on the DOACs was safe. We still don't have the exact data if the patient has very high levels of anti-10A or very high levels of dabigatran, but according to this study, I think that in the very near future, the patients on the DOACs would be treated with an intravenous thrombolysis according to this big, let's say, multi-center retrospective trial. but I think that the prospective part will be even more, let's say, essential, and also will give us even more information how to treat the patients with the DOAC with an acute ischemic stroke. What about the patients with large vessel occlusion? On the DOACs, they are always eligible for endovascular treatment. I will just mention one subgroup of patients that could need the triple treatment, so the double anti-aggregation treatment and the treatment with oral anticoagulation. These are the patients with the ICAT that we've already had a very nice lecture before. We know that there are no clear guidelines how to treat the patients who need a stent placement, and then they also need oral anticoagulation. There are guidelines regarding the double anti-aggregation treatment in patients just requiring the stent placement, but regarding the additional oral anticoagulation, we always need to balance between the rate of the ischemic stroke and also the rate of the hemorrhagic complications. So the CHATS-VAS score and the platelet score is mandatory. What I can say, the multidisciplinary approach is always crucial if we have a patient who needs the oral anticoagulation and also the double anti-aggregation treatment. Of course, we need the international registries and what would be the best prospective randomized trials that are crucial to advancing research in this very important topic. So I would like to thank you. I'm completely on time with my presentation. So what we definitely need to know, that I think that in a very near future, the patients on the direct oral anticoagulation treatment who suffer an acute ischemic stroke would be treated with the IVT, just the same as the patients who are not on oral anticoagulation. But we are still awaiting several of the trials that are running and also the data from the additional registries. So thank you very much.
Thank you, Professor Paul. Very insightful presentation.
Thank you. Shall we go down?
We now have a couple minutes to open discussion, and I would like to invite our esteemed speaker to join me at the discussion table at the front. For audience? Oh, okay.
Terima kasih. Izin bertanya, saya Agung Nugroho. Pertanyaan pertama kepada dokter Kesehadi. Dokter, kami pernah membaca suatu artikel di jurnal tentang time is collateral, dan paradigma yang kita anut sekarang adalah time is gain. Seberapa kuat menurut dokter peran penting dari kolateral pada manajemen stroke infark yang subakut atau akut, jadi yang tidak beruntung datang di fase berakut ke center stroke management untuk mendapatkan EVT atau thrombolysis. Then my next question to Professor Froll about your trial in giving an igalizumab in patient with acute ischemic stroke, which doing the EVT. How long you give the igalizumab before the EVT was done in your trial? Thank you. Right.
Terima kasih dokter atas pertanyaannya, bahwa sebagaimana pentingnya aliran kolateral pada stroke ischemic itu pada fase akut, ya, sangat penting. Tidak ada yang jauh lebih penting daripada aliran kolateral itu. Yang Tuhan menciptakan 3 jenis kolateral. Ya. Yang pertama adalah sirkulus visi, ya. Yang kedua adalah ekstrakranial. Kemudian yang ketiga adalah leptomeningeal anastomosis. Itu harus kita pahami. Jadi pada fase akut itu bagian dari otak, ya, pasti ada yang mengalami hipoperfusi. Seharusnya pada saat itu, ya, aliran darah yang ke daerah mengalami iskemik itu tinggi. Makanya kita tidak dianjurkan untuk menurunkan tekanan darah pada fase akut, karena sangat-sangat bergantung dari tekanan darah. Kalau kita lihat dari angiogram, ya, jika ada oklusi misalnya pada M1 atau M2 dari middle cerebral artery, kemudian kita turunkan tekanan darahnya, yang seharusnya ada kolateral dari ACA distal, anterior cerebral artery, untuk membentuk kolateral dari membentuk leptomeningeal anastomosis, kita turunkan tekanan darahnya, itu akan menyebabkan impak pada daerah MCA, dan itu bisa menimbulkan apasia, ya, apakah dan defisit neurologis yang berat. Tetapi kalau kita biarkan kolateral itu jalan, ya, ditambah dengan misalnya penggunaan antiplatelet, statin, ya, saya kira itu yang harus kita pertahankan. Jangan buru-buru menurunkan tekanan darahnya, sangat-sangat penting. Begitu pula pada kasus jika kita ingin melakukan mechanical thrombectomy. Pada kasus di mana kolateral tidak ada, itu jauh lebih buruk atau lebih buruk hasilnya jika dibandingkan pada kasus yang memiliki kolateral atau leptomeningeal anastomosis. Seperti itu. Makanya itu sangat penting buat kita. Jadi seberapa penting? Sangat penting buat saya. Dan mungkin semuanya. Saya kira itu. Terima kasih.
So thank you very much for this, I think, very important question. We are waiting approximately 10 minutes before we give then the IPT, so the lerocizumab, and then wait max up to 10 minutes. But there are also, let's say, lots of case reports and case series that they were waiting only for 5 minutes, but wait 5 to 10 minutes, I think it's enough, and then proceed to the lerocizumab treatment, the IPT treatment after the lerocizumab. So max 10 minutes.
I have two questions for
Yes,
for
please.
Yeah, first question is in the ischemic stroke case with non-popular arterial fibrillation, and after that we try to see the chest pulse value, and we found one. But can you prepare for this patient? You will give the patient drug or antiplatelet or no. If the patient just has one chest pulse, if we found patient with stroke ischemic with non-valvular atrial fibrillation and the chest value just one, but can you prefer give the patient no antiplatelet or antiplatelet or anticoagulant, warfarin or NOAC?
If the patient does not have AF, so there is no indication to anticoagulate the patient. So you need to have clear indication to put the patient on oral anticoagulation treatment. So in case of atrial fibrillation, in case if someone had pulmonary embolism, and then the acute ischemic stroke, then you can anticoagulate the patient. But otherwise, it is not indicated. So after stroke, you treat the patient if it's not according to the AF, you just put the patient on antiplatelet treatment, if I understood from your question.
But how about if the patient has also AF but not valvular?
So if the patient has like, you mean the artificial heart valves?
Yes.
In the case of artificial heart valves, we still need to put the patient on warfarin, because the studies that were comparing the warfarin and the DOACs in these patients' fibrillation, they did not show any advantages of putting the patient on the DOAC. So we still need to put the patient on the warfarin in cases of artificial heart valves. Yes.
We have to use warfarin.
Yes.
The second one is if the condition occur bleeding in the axe treatment,
Yes.
yeah, with kind of antidote or reversal agent you use.
Yeah.
Because mostly in Indonesia we just use protamine sulfate. Yeah.
Okay. In patients who suffer ICH on the DOACs, so in case of dabigatran, we always give the patient
Like
the
di Sabah dan Gatran.
For dabigatran, we always give the patient either rituximab, so the specific antidote for the dabigatran. In patients who suffer ICH on apixaban or rivaroxaban, there are several factors that you need to have in mind which treatment would you give to this patient. So if we know that the patient is eligible for neurosurgical treatment, so for the evacuation, we know that andexanet alpha is not indicated in this patient subpopulation. So we usually give the patient the PCC, so the prothrombin complex concentrate, before surgical evacuation. There is still not enough of the data if we can give the andexanet alpha and then proceed with the neurosurgical treatment. So for the patients who are on edoxaban, according to the guidelines, we still give the patient the PCC, so the prothrombin complex concentrate. There is still not enough data to treat the patient with andexanet alpha, also not in cases they will need the surgical evacuation. So for the patients who are on edoxaban, we give the PCC. But in the patients who suffer spontaneous bleeding and they are not candidates for the neurosurgical treatment, then they are on rivaroxaban or apixaban, you need to somehow weigh if you will give the patient the andexanet alpha or PCC. We are usually taking a very good history if the patient already had any thrombotic events, let's say in the past, because we know that the andexanet alpha can higher the probability of suffering thrombotic complications in giving the patients the andexanet alpha. So, but if there is like no history of these thrombotic events between the patients with andexanet alpha, we have this higher dose and then the lower dose. It depends on the time of the intake of the factor Xa inhibitors, but otherwise we give the PCC. But andexanet alpha or the PCC, it depends on the characteristic of the patient. Yes.
Last, yeah, that one. I know Indonesia very different with your country, yeah, and you already mentioned if we have to see the title of the act when we will give a reversal agent or maybe we will go to the next procedure. But do you have suggestion for us? Maybe is there any parameter to see activity is like maybe not because in Indonesia
Yeah, so when we have a patient who presents with the signs of an acute ischemic stroke at our emergency room, so we immediately take the blood and then we measure the levels. So for dabigatran, we have specific thrombin test, which is called the hemoclot. And then for factor Xa inhibitors, we have specific anti-10A for rivaroxaban, apixaban, and edoxaban. So we get those levels quite quickly. And of course, if the patients are not taking the DOAC, you see that the levels are very low. So you can proceed with the intravenous thrombolysis immediately. But for the patients who are on dabigatran, we do not wait to get the result of the hemoclot, because it does not matter if the patient will have then the ICH or the acute ischemic stroke treatment. We always give the rituximab and then proceed regarding if there is an ICH or if there is acute ischemic stroke with the intravenous thrombolysis. So we don't wait to get the result of the hemoclot from patients who are on dabigatran treatment. But for the other patients, yes, because we know that we cannot give them dextran alpha prior to IVT. So, but if we have the levels, we can treat the patient with the IVT if the levels are below this normal limit. But as I said, I think that the guidelines are going to change in the near future because there is more than, let's say, enough of reassuring data the patients on the DOACs can safely be thrombolized. But we are still waiting for this prospective 2-IT trial, which is, I think, running quite efficiently. But according to this retrospective 2-IT and also according to the data from the 6th registry, I think that it is safe to thrombolize the patient on the direct oral anticoagulation. But the only problem right now is that we still gather the data if the patients have very high levels of the anti-10A or the levels of hemoclot in acute ischemic stroke. But I think that these things are going to change in a very near future. But there is one question: if we will be able to thrombolize all the patients on the DOAC, do we still need to give the patients on the dabigatran the idarucizumab prior to thrombolysis or not? So this is a very important question. We know that we have a very big cohort from New Zealand. In New Zealand, I think that they have, let's say, the most important data because their cohort is really big. So when we were analyzing the data from these 2-IT registries, so the retrospective, the New Zealand had more than 250 patients that they put into the registry, and they treat all the patients with the idarucizumab prior to intravenous thrombolysis. And IVT was super safe, and it was also very effective. Maybe just to mention, what we also get as a very important fact from this 2-IT registry was that the thrombolysis in patients who were on oral anticoagulation, if you are comparing to the data of the non-anticoagulated patients, so the IVT in patients who are on oral anticoagulation is even more effective comparing if the patients are not anticoagulated. So I was doing this for my PhD study very long ago with the hypothesis that patients who are on oral anticoagulation, they are more prone to intravenous thrombolysis because these thrombi are more prone to lysis. There are several, let's say, mechanisms beside this story why the thrombolysis is much more effective. But as I say, what we also see from the everyday clinical practice, the patients that we thrombolize on the oral anticoagulation, they usually walk home. So I think that the thrombolysis on the oral anticoagulation is definitely much more effective than if the patients are not on oral anticoagulation. But as I said, we are still waiting for the results of several trials that I think are going to change the everyday clinical practice.
Thank you, Professor.
Very interesting discussion. Thank you, Prof. Maybe another time, or time is up. Or one small question for Dr. Tan. Maybe our audience wants to ask Dr. Tan. Dr. Tan, are you still with us? Can you hear clearly?
Okay, good night.
Okay,
Good evening, Dr. Tan. This is Fritz. Thank you for your interesting presentation. One thing that I would like to ask you, how about aspects from 0 to 2 consider to intravenous thrombolysis? Is this still have a place? Thank you, ma'am.
Hi, Dr. Richmond, nice to meet you. That's a pretty tough question because most of the trials that looked at intravenous thrombolysis were in patients who didn't have a large area of ischemic infarction. So to have patients who present in the 4.5 hour window with an aspect version 2 is really uncommon. And so even if you have those patients, I think you might hesitate to give the drug because in general it's contraindicated in patients who have large areas of ischemic infarction. So aspect version 2 would be in that category.
Thank you.
Thank you.
Thank you, Dr. Tan, for the question, for the answer. I think time is up. Let us to conclude this Symposium 5. Thank you. On behalf of this organizing committee, I would extend deep gratitude to our speaker, Dr. Azhari Bahar, Dr. Tan Huyen, virtually, and Professor Sandra Froll. Give the big applause for our speaker.